Welcome to our deep dive on the Enterobacter Cloacae complex. This is designed specifically for you, medical microbiologists. Now, just so you know, this entire explainer is sourced from a Gemini deep search. If you want to check out the full references, and I know many of you will, you can find them in the accompanying notebook document.
Okay, so here's our game plan. We're going to follow the logical path you'd see in a clinical encounter. We'll start with its tricky dual nature as a pathogen, dig into the complexities of just figuring out what it is, talk about treatment, and then wrap up with how to keep it contained. Let's get into it.
First up, let's explore the fundamental paradox of the Enterobacterium Cloacae complex. This is really where the story begins.
So here's the thing. For most of us, this organism is just a harmless resident of our gut. But in a healthcare setting, it completely transforms into a formidable pathogen. We're talking about infections with mortality rates as high as 46% for bacteremia. That's a huge number.
And what's the main reason it's so tough to fight? It all comes down to its built-in secret weapon, the inducible AmpC beta-lactamase. This thing can actually emerge during therapy, which can lead to sudden and catastrophic treatment failure. It's a massive challenge.
Now, just when you think you've got a handle on it, the problem gets even bigger. And that's because we're not just dealing with one single bug here. Not even close.
For the longest time, we thought Enterobacter cloacae was just a single species. But now, we know it's a whole complex of species, at least 6 core ones, and that number is still growing. And the tricky part is, they all look almost identical phenotypically.
And check this out. This chart really drives home just how big of a diagnostic problem this is. Your standard MALDI-TOF systems, the workhorse of so many labs, can be right as little as 25% of the time. Think about that. It's often misidentifying the most common species.
So why does this matter so much? This isn't just some academic debate. It has real-world, life-or-death consequences. When you fail to identify the specific species, like the hypervirulent Enterobacter brigandensis in this tragic NICU outbreak, you can completely miss the epidemiological links and delay interventions that could save lives.
So, what do these infections actually look like when they show up in the clinic? Who's at risk, and what are we seeing?
The Enterobacter cloacae complex is a textbook opportunistic pathogen. It's causing big problems like bacteremia and ventilator-associated pneumonia or VAP, but it's really picking its targets, the most vulnerable patients. We're talking about those in the ICU, people with central lines or other devices, or those who've been on broad-spectrum antibiotics. Okay, this all leads us to the million-dollar question. How do we treat this thing effectively? And well, the answer is pretty complex.
You know, what's really fascinating here is that the treatment philosophy is not universal. It differs a lot, depending on which major guidelines you're looking at.
So let's start with the Dutch SWAB guidelines. Their whole approach is built around risk stratification. They save the big guns, the carbapenems, for high-risk patients. For others, they're open to carbapenem-sparing options, which is great for promoting stewardship.
Now contrast that with international guidelines, like from the IDSA. They're looking at it from a totally different angle. They focus on that pesky AmpC mechanism itself. They strongly advise against third-gen cephalosporins and instead prefer cefepime because it's just more stable against that AmpC enzyme.
So let's boil it down. What's the core difference here? The SWAB strategy is based on the patient's risk profile. The IDSA strategy, on the other hand, is based on the biochemical battle between the antibiotic and that resistance enzyme. Two very different ways of looking at the same problem.
And what about kids? Well, for pediatric patients, the principles are pretty similar. Cefepime and carbapenems are still your go-to agents. But prompt source control, like getting an infected line out, is often the single most critical factor for a good outcome.
All right, with all those clinical challenges in mind, let's switch gears and head over to the lab. How does this all come together in the actual diagnostic workflow?
The identification process follows a pretty clear path. You start with the basics, the gram stain showing gram-negative bacilli. Then, on a McConkey plate, you'll see those classic mucoid pink colonies. From there, you move to the biochemical profile, indole negative, VP positive, citrate positive. And finally, for that definitive species ID, you really need molecular methods like sequencing. And here's a perfect look at its built-in resistance. Thanks to that chromosomal AmpC, it just naturally shrugs off things like ampicillin and first-gen cephalosporins. In fact, EU-CAST expert rules say you have to report these as resistant, no matter what the in vitro results say, just to stop anyone from using an inappropriate therapy.
And when you're staring at those susceptibility reports, that little letter I from EUCAST is absolutely vital. That I stands for susceptible increased exposure, and it's basically a heads up that you need higher, more targeted dosing to actually beat this bug.
Finally, since identifying and treating this organism is so challenging, it's pretty clear that prevention is absolutely paramount. An ounce of prevention is worth a pound of cure, right?
And the strategies for control aren't revolutionary, but they have to be followed religiously. We're talking strict hand hygiene, contact precautions, isolating or cohorting patients, meticulous cleaning, and of course, really smart antimicrobial stewardship to reduce that selective pressure.
And all of this leaves us with a really critical question for the future. We know this complex is constantly evolving. The real challenge for us is to make sure our strategies for identifying it, treating it, and preventing it are all evolving right along with it.
Hey, if you found this deep dive helpful, we'd love for you to subscribe for more explainers just like this one. And more importantly, we really want to hear from you. Share your own experiences, your insights, your feedback, all of it, down in the comments below. Thanks for watching.